All right. I think with that, why don't we go ahead and get going? So, welcome to the Implementation Science Working Group. Today we're having a presentation really about an equity-focused implementation framework and explorations into sort of how that was developed and applied from the New Zealand context. So we actually reached out to Sue and Papillon in the fall as we were sort of planning for the spring. And we found their really interesting work based on the scoping review that they had done reviewing different equity frameworks for implementation science. And so, based on our survey and interested folks last year, we want to make sure people expressed an interest in learning more about equity focused IS. And so that was really formed the basis of what we're inviting them here to talk about us today. I think it might be our first international presentation, actually. I can't recall another one. Maybe I'm missing one. But we're really excited to have them. So just to briefly introduce, we have Professor Sue Crengle, who's a professor based in the Maori Health Research Unit at the University of Otago in New Zealand. So she's a general practitioner and public health medicine specialist and focuses on inequities in health and health services research. And we also have Papillon Gustafson, who's a postdoc fellow, also at the same university, and her research focuses on improving health equity using implementation science approaches with some background in neuroendocrinology and medical communication. So we'll have them speak, and then we'll have some time for discussion and questions like we have kind of typically at the end. So with that, I will pass it over to them. Thank you so much.
Thanks. Kia ora, Julie. He mihi nui ki a koe, te kaiwhakahaere o tēnei wānanga, tēnā koe, huri noa ki a koutou katoa, ko taima I roto I te kaupapa o te rā, tēnā koutou, tēnā tātou katoa. So just really wanted to acknowledge and thank you, Julie, for your invitation and acknowledge everyone who's gathered here today. It's very nice to see you all on the internet, on Zoom. I'll just share my screen. No, that's the wrong one. There we are. Share. So as Julie said, my name is Sue Crengle. There we go. I am a general practitioner, which I think in the US is a family medicine doctor and a population health, public medicine, public health doctor as well. And yeah, I'm thrilled to be talking to you. Of course, Pappy and I are here talking to you, but we are members of a large team of people who focused on this work from academic, community, primary care, and secondary care sectors. And just wanted to acknowledge all our friends who have been part of this work. Very briefly, I thought I would just briefly cover some context for Aotearoa, New Zealand. So our health system, we have universal health care, although there is a part charge for people accessing their primary care services, and hospital services are free. There's a $5 per prescription item part charge to a maximum of $100 a year, and after that, pharmaceuticals are free to the patient. Accidents and injuries are covered under a no-fault national insurance scheme, and that's funded through partly through taxation. We also have a private hospital system where people can either self-fund or have private insurance. And increasingly, there is public funding, government funding of procedures that are unable to be done in the public system, and the private system is funded to do those procedures. They are, of course, exactly the same surgeons, exactly the same anaesthetists, and there is a view in New Zealand that particular government approaches are kind of deliberately running down public services at the moment in order to bring about kind of a more private focused system, kind of by stealth. So that's kind of our current setting. Um, our health system at the moment is under extreme pressure. About 4 years ago, we began a restructuring of our health system. And that really, I mean, any major, our health system has 80,000 employees. It's very large, and any restructuring in such a huge organization carries its own stresses and challenges. However, in my view, what that the reforms are not the sole reason for the challenges we're seeing at the moment. And in fact, I think that you can sheet the underlying fundamental causes of some of the challenges we're seeing at the moment to about um, 18 years ago, where we had a 9-year government that, apart from a per capita increase, there was no increase in funding for health apart from a per capita increase. So, I mean, I think that was really the beginning of some of the challenges that we see in the system now. Māori are the Indigenous people of Aotearoa. I am Māori myself, and my iwi connections are to Kaitahukati Māmoe and Waitaha, which locate my connections to the very bottom of the South Island. We make up just around 18% of the population in the 2023 census. And like many Indigenous people in countries that have been colonized by European people, we have the experiences of the impacts of colonization from the time of the beginning of that process. And fundamentally, we still see actions, particularly by governments, that reflect colonial ideology. And we also experience significant racism, both institutional and in particular institutional racism, but also sometimes personally mediated racism as well. In New Zealand, we use ethnicity, we don't use race. We think that often race is constructed as a biological concept, but of course it's not. There's no evidence for a biological concept of race. And so we use ethnicity, which is a social construct. Self-identified, people can have as many ethnic groups as they choose. And then that data can be outputted in a number of different ways, and we have guidelines for how to do that. Māori experience significant inequities in the social determinants of health, access to and quality of care. And as a result, we experience adverse health outcomes in almost every area, both in the incidence of diseases, but also in hospitalizations and mortality outcomes. This is just one example. So this is life expectancy, and on the left you can see that over time life expectancy has increased. This is for the blue line is Asian. Sorry, that's Asian. This is Māori. This is European. And this is Pacific peoples, and this dotted line is the overall life expectancy. So Māori life expectancy is lower than European people, who are often, our major comparator. But good news is it has improved over time. This is another representation of that, showing the life expectancy gap, and the purple is for Māori, and again, reducing over time. And this is by socioeconomic status. So this is a small area geographic measure. It's in quintiles. It's called the New Zealand Index of Deprivation. And you can see the very common finding that as deprivation increases, life expectancy decreases. But for Māori, our life expectancy is lower within each strata of deprivation. And there's also a gradient, what we call a gradient gap, where the gradient of change over increasing deprivation is greater for Māori. Why do we think that health equity-focused implementation science is important. Well, we know that if we implement interventions that are evidence-based, then we see improved health outcomes. But to do that, we need to do that well, and we need to do it in a way that is the benefit of those interventions is equitably experienced across population groups. And in New Zealand, we don't have that. We see unequal benefits from a lot of interventions, including cardiovascular disease risk assessment and all types of cancer screening that we have in New Zealand at the moment, where the reach to Māori communities is lower than to European communities. We have seen increasing efforts to address equity in implementation science internationally, and obviously here at home. And from our point of view, we see equitable implementation as being interventions that are provided in a fair and just manner. A current discourse that I'm using because it suits the current government's ideology is about equal opportunity to benefit from interventions. Equitable implementation also accounts for social disadvantage and inequitable health system delivery. And really, we want to ensure equal outcomes for everyone. So I think I've probably all talked about this, but we see in New Zealand, sometimes evidence-based interventions don't get implemented or don't get implemented well. We also have seen that interventions that have the potential to improve equity gaps are not having the benefits that they could have. And people working in our health system want to have conversations about equity and how to address these health inequities. But often they kind of get stuck on that how to do it. So we thought that we would want to develop some tools to support the mainstream. And by mainstream, I mean so in New Zealand, we have a small number of primary care services that are provided by Māori organisations. And so we're talking really about mainstream organisations that are government funded and deliver services to everyone. And so we thought that implementation science had a lot to offer to support the so-called mainstream. And we wanted tools that were tailored for our context. We were lucky to receive funding from a national science challenge called Healthier Lives. And we had two phases. The first was to develop a scoping review and to do some stakeholder and researcher interviews and some workshops with consumer and Māori advisor group representatives. And then from those, we developed an equity-focused implementation science framework for use in New Zealand, and also a readiness assessment tool for health teams or services or funders and planners to use to identify the facilitators and barriers in their environment to actually implementing intervention equitably. We had a theory of change that helped us to develop that. And then we piloted and tested our outputs and revised them as necessary. We've developed a user guide and a website. And with that, I'm going to hand over to Papillon.
Thanks so much, Sue. And thank you all for the invitation to come and speak to you today. Really appreciate it. Okay, so in this next part of the presentation, I will give just an overview of our FREA framework, so the Framework for Effective and Equitable Implementation Aotearoa. I'll give some information on how we developed the framework and then show you the framework and its components in some closer detail. So the aim of this study was really to develop or adapt an equity-focused implementation framework that would help support the delivery of health interventions in an equitable way in Aotearoa, New Zealand. So as Sue mentioned, we had a particular interest in supporting mainstream health services to do this, and on health equity for Māori. The development process for the framework involved 6 key steps, beginning with a scoping review of the literature. So we wanted to have a look both locally and internationally and see what kind of equity-focused implementation theories, models, and frameworks were available. And close in time to this, our wider research team also undertook interviews with a range of stakeholders and researchers to get their experiences of designing and delivering health interventions in New Zealand. And so this group included people who were clinicians, people working in health services and management roles. We had some people working in NGOs, we had experts in Māori health, and we were able to gather some really diverse perspectives on real life experience with intervention implementation in New Zealand. So we then, following those 2 key pieces of work, undertook a workshopping process where we looked at the outputs both from the scoping review and from the interviews. And through this workshopping process, we decided that actually adapting an existing implementation framework could be a really a path forward for us. And so the framework that we selected was the Acquire framework, and I'll talk a little bit more about that in my next slide. We went through this process in partnership with our Indigenous, our Māori advisory and consumer advisory groups. And so with this group, we showed them the frameworks that were available. We showed them the one that we thought we could adapt. And then we went through the adaptation process with them. And so I'll talk about the adaptation process as well when I show you the framework in closer detail. Once we had our first version, our first iteration of our framework, and we then went through a mapping exercise just to make sure that the themes that came through from our qualitative research with those interviews in step 2 were well represented in the adapted framework. And just step 6 there is really around just reinforcing that we went through sort of multiple revisions and consultations and partnership work with our Indigenous and consumer advisory groups. So just briefly on our scoping review findings. So we identified 15 theories, models, and frameworks that met our inclusion criteria. And these were, in this particular review, we were focused on theories, models, and frameworks that had an equity focus, either through explicitly having equity as a stated aim or equity-related domains in the framework or theory or model. We were also interested in any theories, models, or frameworks that had been applied in implementing interventions in populations experiencing ethnicity-related health inequities. And so we identified these 15 theories, models, and frameworks. And in terms of what we found, we saw that there were a lot of new or adapted frameworks coming out in this process category. So I'm sure many, if not all of you, are familiar with Nielsen's way of describing theories, models, and frameworks in 5 different categories. And the process models are those ones that are focused on kind of the steps or stages of implementation. And so it's probably not that surprising that in this new space where people are wanting to do equity-focused implementation work, that you're getting these kind of process type models they're coming up out in the literature. We did also see a couple of determinant frameworks. So these are the ones that are focused more on understanding the factors that influence implementation success, so as facilitators or barriers. And we saw a couple in the evaluation category as well. And so these are the ones, both the adaptive Proctor framework and the extension of REAM. These are, of course, established frameworks that had been adapted with an equity focus. So it was the acquire framework that we decided to adapt for our context. And the reason that we chose this model is firstly that it does provide that kind of step-by-step guidance right from planning through to evaluation. And we just knew from our research team's experiences working in the health sector, and also what we learned from our qualitative work, that those interviews, that having some really good guidance through the step-by-step process was a gap in Aotearoa, New Zealand, and somewhere where an implementation science framework could make a real difference to the way that implementation is approached, and providing a real systematic framework for how that could go about. We really liked that it had this very visible equity lens at every step. It's a people-centered model. Its foundation is around the determinants of health, which of course we know are so essential for understanding health inequities and also influencing implementation. And then of course it visually represents an iterative approach, which we liked as well. So we took these core aspects of Acquire and we built upon them to develop our framework for effective and equitable implementation in Aotearoa, or FREA for short. And we made some key adaptations, and so I'll just talk through those briefly now. So the first kind of main adaptation was that we made the foundation of our framework, the principles of Te Tiriti o Waitangi. Te Tiriti o Waitangi, or the Treaty of Waitangi, is the written agreement that was signed between Māori and the British Crown in 1840. It has 3 articles that have been interpreted in principles, and there's 5 principles that have been identified as relevant for the health and disability sector. And so these are tino rangatiratanga, which is a Māori language term meaning like self-determination, autonomy, self-governance. There's a principle of equity, active protection, options, and partnership. And so we felt like by having Te Tiriti o Waitangi as the foundation, these principles as the foundation, that this would be its essential grounding for any kind of intervention, design, planning, implementation, anything like that that's happening in the New Zealand health sector. We also added some core constructs, and so these were things that in particular had come through the interviews and also through some of the other local implementation science literature, and things that we felt were really important to have visible and for people to be thinking about as they're going through these the steps of planning, designing, implementing, and evaluating. And so these are collaborative design, having an anti-racism approach, utilising Māori and priority population expertise if the intervention is being implemented in, for example, a Pacifica population or another priority equity group. Also having a culturally safe approach to any kind of research or interactions with the population who are receiving the health intervention, and also a values-based approach. We also revised the research focused language of Acquired just to increase, hopefully, the usability of our framework in service settings. We wanted something that could be used both kind of across academic work, but also in practice. We added a step to prompt community engagement and leadership in planning early on, and we felt like this wasn't made quite explicit enough in Acquire, and this is something that's really important to happen early on, particularly for ensuring equitable implementation. And we also added an action step for implementation. So this is where implementation is actually ongoing, and we just really want to encourage people to be actively monitoring their metrics, particularly their kind of equity implementation metrics. And so we felt like having this as a defined step was a really good way of representing that. Oops. And so now I've jumped a slide here, sorry. I'll just go through each of the kind of the steps in a little bit more detail. So first of all, we've got implementation planning. This has got 4 sub-steps, and it begins with designing or selecting an intervention with implementation in mind. And so the idea here is that the intervention would have been designed with an equity focus, or perhaps it's been selected because it's addressing a particular health inequity, but it may need some sort of adaptation. And so getting the users of the framework to think about those implementation questions really early on was something that we wanted to encourage here. The next sub-step is around identifying involving key stakeholders early, if they haven't already been part of designing and selecting the intervention, which would be the ideal scenario, but is not always the case. We then have identifying the barriers and facilitators to equitable implementation. And so depending on the intervention and depending on the setting, this might involve some document searching, some interviews, some background research, and maybe utilising the expertise of those stakeholders for them to give their perspectives from their positions of experience. And then the final sub-step is around identifying measures of implementation and intervention effectiveness. And again, consulting with that stakeholder group to get their insights on what they consider to be implementation effective success, and building that into how that might be measured. The next step is around designing the implementation pathway. This begins with good communication. We know that communication is so important for equitable implementation, and this is such a broad term, but it really is just encompassing the communication between organisations, within organisations, between and within teams and services, communication between the group implementing the intervention and those who are receiving it, and also thinking about the way that people navigate the health system. So it might be resources that are specifically related to the intervention itself, but also the kind of broader health system literacy and what barriers there might be in the health system to helping people to equitably access that intervention. The next step is around defining resources required for equitable implementation and then building on that to design some strategies. Designing the monitoring and evaluation metrics is the last sub-step. And then we've got that active step of where implementation is occurring and some ongoing monitoring. And so we followed on we took a choir's approach here. They included Proctor's implementation outcomes framework as their implementation outcomes, but you could put in whichever evaluation framework you wanted to use here. So for example, you could use REAIM or an Indigenous evaluation framework, whatever has you've been able to adapt to have a kind of an equity perspective. The example I've provided here is for the Indigenous evaluation framework is Hippikinga Waiora implementation framework. So that's the only other kind of dedicated implementation framework that's come from New Zealand at the moment. And this framework can be used to evaluate outcomes related to cultural centeredness, community engagement, integrated knowledge translation, and also systems thinking. And then we've got the final step, which is outcomes and evaluation. So this is around, again, some sub-steps, which may or may not be, depending on what kind of intervention you have, you might not be doing all of these, but it's around assessing implementation effectiveness, intervention effectiveness, evaluating any adaptations to pathways that may have been made, and then an overall assessment of the pathway, paying particular attention to any inequities that were identified, what the potential causes of these were, what are some actions that could be taken to address these, and who is accountable for making these actions happen. I think one of the things that we've learned through this work, and also just from the collective experience of our research team, and I guess it's common knowledge really as well for people working in the spaces, often things are identified, but having someone who takes ownership for making the action step can be really hard, particularly in big organizations, and where people feel like they don't have a lot of power or influence to make some big changes. So we'll probably talk a little bit more about that in some of our equity readiness assessment tool stuff. But that brings me to the end of this very kind of whirlwind overview of our FREER framework. And I just wanted to finish with this last question that we had. So we wanted, we were left with the question, how could services, organisations and teams who have used this framework to design an implementation pathway know that they are ready to implement their intervention and do so in a way that will be equitable? And so that's where we came to develop our equity readiness assessment tool. And so I'll pass back to Sue now to talk about that piece of work. Thank you.
Thanks, Pappy. I'm going to talk about the readiness assessment tool. And so as Pappy suggested or discussed, we identified a need to assist with the how work of equity improvement in health services. Organisational readiness is, I believe, comes from organisational psychology. And really, we're thinking about it in the context of how ready is our team, our service, our health system to roll out interventions that will improve inequity, or at the very least, not increase them. And equity readiness is the willingness and ability of a service or organisation to implement an intervention in a pro-equity way. So we did a literature review of various readiness assessment tools, and we thought that the Wandersman Centre Readiness Thinking tool was applicable as the basis, and again, we adapted it to meet requirements in Aotearoa. So we had 7 steps. Our interviews with our key stakeholders were also used to identify facilitators and barriers to implementation. We reviewed the existing tools. We had a researcher workshop to develop key domains of equity readiness in our context in Aotearoa and in the health systems and services. We also did some interviews with key stakeholders, to identify their experiences with equity tools. We then developed the equity readiness assessment tool from the Wandersman tool, pilot tested it and made final revisions, and developed supporting resources so that people were able to use the assessment tool. Our tool includes 31 self-rated items across 3 levels of readiness. And you might think, oh, 31 items, but actually they're pretty quick and they're on a like-it type scale. There are 3 levels, the individual, so the extent to which I, as an individual, am motivated to implement the intervention and to ensure that this is done equitably. The intervention itself, so what is needed to make this particular intervention happen in an equitable manner, because what's required is not the same for every intervention. And then organisational items related to both people. So do you have the people with the roles and the knowledge and the skills needed to support equitable implementation in your team? So, for example, if you don't have the support from senior managers, then you may well struggle to get broader organisational support for what you're trying to do. And then systems and processes. Does your team or service or organisation have the required systems and processes that are going to support the work that you're doing? Individuals that are involved in the implementation will complete the tool themselves, and then we'll come together and have a facilitated discussion to identify the similarities and differences in the individual's responses, and to identify what some of the issues might be, and to create an action plan that will allow the team to overcome any identified barriers and to strengthen the facilitators. So we've got a website which you can see at the top of the slide, and I really invite you to go and have a look. I think you get a much better feel and idea about the tool from this very crowded screenshot of it. As I said, 31 items sounds a lot, but actually it's very quick for people to do. In our pilot testing, we had 4 teams who were working on different health programs that had a specific equity focus. And that included a team where at the moment I'm leading a program of research on to design a lung cancer screening pathway for New Zealand that works equitably. And so that included our lung cancer screening team. In general, we got very positive feedback on the readiness assessment process. The teams reported that they felt that it really gave them a better understanding of equity readiness and gave them different dimensions to consider that they otherwise would not have considered. They felt that it was a good team building exercise, that the time commitment was reasonable, and that it was useful for demonstrating readiness to implement or to scale up existing interventions to a range of groups, for example, to funders or to iwi Māori tribal partners. One of the key challenges was that they felt that people reported that there was the potential to create disunity if there were unmet expectations or disagreements or perceptions of readiness and inaction. And they felt that the process of developing an action plan was challenging for all teams and raised questions. For example, what does a team look like for the purpose of freer readiness assessment? What response options are needed in the tools, including categories and free text, to ensure good facilitated discussion? What can the facilitator do to make sure the discussions stay focused and culminate in our action plan? And what extra resources and support are needed? And for example, an action plan template. So as a result, we did develop a suite of resources to support the use of both the framework and the readiness assessment tool, and they're available on our website, and you can see the address there. We are currently applying both the framework and equity readiness assessment tool in a number of projects. Well, actually, other people are applying them, and we're working alongside them to test and to get feedback from them about how the tools perform in practice. We've hosted 2 implementation science masterclasses to upskill local people who are interested in implementation science. We currently don't have any university level courses in implementation science, so that's a gap that I'm talking to our university about. And we're continuing to socialise the framework and the tools through our own clinical and professional networks. So thank you very much.
That was great. I particularly like that you're thinking about how to train other people and how to do implementation science even at a basic level. I think that's really, really great. So while we're gathering some questions, maybe I'll just start with a quick one. I wanted to hear maybe a little bit more, because you're right, like this equity focus and how to bridge this into implementation frameworks, I think is just really picked up in the last 5-10 years in particular. And, we've grappled a bit in our work with what type of framework to choose and whether one with an add-on or an really equity-focused framework is what we're going for. And I would love maybe a little more exposition about what your thoughts were about how you chose Equer and whether that would work for many different types of projects, or if you think like some of the other add-on ones are appropriate.
Yeah, I might start and then I'll hand over to you, Peppy. But I think in the literature review, when the team sat down to think about, are we going to develop our own framework? Because that was definitely, and I think in our original thinking, we were thinking we would be developing our own framework. But then when we looked across them, we definitely felt that some of them we could modify to suit our context, and that seemed much more sensible than kind of reinventing a wheel, particularly in a progressively more and more crowded space, you know. So we sat down and went through each of the frameworks that were identified and discussed them and talked about what might be the most appropriate one. And I'll just hand over to you, Peppy, if you've got any additional comments.
Yeah, that's right. And we had one of the key people in our research team works in a health service role, a senior health service role, and she has a lot of oversight of implementation of a range of interventions and programs with differing levels of complexity, and her voice and her experience and her advice on what she was hearing from the people that are working for her, and the kind of support that they require was really quite instrumental in how we went about our selection process. I mean, we were guided by the fact that we ultimately knew we wanted something that went through kind of steps or stages. So that helped narrow what we were looking at in the first place. But yeah, it was that perspective that we had kind of at our forefront of what is something that can help people who are in service settings to do this better. And it felt like something that was steps or stages focused was probably the kind of the most sensible approach. It's really, I mean, as you know, there are hundreds of theories, models, and frameworks, and each time a group adapts their own, there's yet another one, and we've made our adaptation, but there might be someone who then adapts our adaptation to their context, and it does, there is a lot, and it does create questions around how you make a selection. And I think, often people get, and I don't think this is wrong, people get very comfortable and familiar with using a particular framework, and so they go back to that one again and again. And I don't think there's anything, wrong with having one that you're familiar with, as long as particularly if you're starting to ask different questions around equity, and if it's not got specific prompts in it, then starting to have a think about what those important questions are and how you might reframe the standard domains that are in whatever framework or model, and kind of reimagine that with an equity lens. I don't think it necessarily has to be a published piece to use it for your work, but yeah, that was our approach.
I think I'll just add there that I think the point that Peppy made about being explicit about equity is really important, certainly here in New Zealand. That, I mean, people with the best will in the world often won't think equity. And so having it very explicit, I think was very important in our context, to support people to think about and consider equity.
Yeah, that's fabulous. Okay, great. We've heard, I see quite a few questions about the FRIA tool and sort of how to apply it in the Slido. So maybe Becca, if you want to ask your question, I think related to how FRIA applies, maybe that would be helpful to start with.
Sure. Happy to. So thank you so much for your talk. This was really wonderful. And I'm always thinking about how we use these frameworks in a more practical way with our practitioner friends. And it sounds like you had that in mind. And so I was just wondering if you had any examples of practice-oriented folks who have used FRIA in a way that you're like, yes, this is what we were hoping would happen. Have you gotten there yet? Are there people who are really using this in practice right now?
Yep. There are a number of people who are using it in practice. We've got, and across a range of different, particularly allied health, interestingly. So we've got someone who's doing, who's using it around the provision of hearing screening in a particular district in New Zealand that has a high Māori population. Just trying to think. Who else has Michelle been? Michelle, who is one of ours, she's using it, will be using it. She's just started her PhD. So she will be using it in her PhD, which is around a cardiovascular disease medicines health literacy intervention. And so she'll be using it. So there are a number of and Karen's team, Karen Bartholomew's team, is using it a lot. But it's early days and we're still waiting. No one's through the whole process yet.
Sure. That's great. Thank you so much.
Yeah, and maybe related to that, how would you imagine it being, say, broadly applicable to other types of implementation projects?
What do you mean by other
Oh,
types?
the readiness assessment tool, like how could you imagine? I don't know actually know who asked the question. It says anonymous. So how do you, maybe I'll restate. So do you imagine this sort of readiness assessment tool working best in specific settings? Like when I was reading more in it before this, it seemed kind of interesting because it's like a semi-structured approach even to having filled out a survey and then have a discussion actually after that to assess equity readiness. And I'm curious if there are sort of different contexts in which you think it would work better or not.
Yeah, I mean, I think my personal view is that if teams or services are implementing something new, then they should be using both a framework and designing an implementation pathway using a framework, but also looking at if the context is ready. Because you can do the best pathway, the best implementation pathway, but if there's something in your environment that if people don't really care about equity, or if they're too stressed by the current system that they're working in to be able to have the headspace to think equity, or you don't have senior managerial support, so you're not going to get the resources that you need to implement, then you're wasting everyone's time. And so I think it's really important that people take a breath and a step back to spend what essentially is probably amounts to maybe 2 hours, maybe 3, if you have to go back to your action plan, to actually think about the environment that you're going to be trying to work in. So that you don't end up wasting your time, because then everyone gets kind of disappointed and people thinks it's a problem with the intervention, but actually it may well be the environment that's been the issue.
Are there any questions from folks here, or I could keep sort of asking up the slide or other things that I have?
I could just build on Sue's answer
please,
just
yeah.
quickly, Julie, and just say that we really grappled when we were going through the development process around making that key tension between having something that is broadly applicable but not so broad that it's then not specific enough to be usable. And because we are really at the beginning phase of just testing this in a range of settings, I think we'll get that feedback fairly soon. As we've got this kind of diversity of both intervention types, but also that key question around, well, what does a team look like? And so as we get some more practical learnings from people applying it, I think we'll have some better insight into how it actually performs and whether any particular changes are needed depending on kind of what context. Ideally, again, we're focusing on mainstream kind of health services at the moment. That's the kind of where the tool is pitched. That's where we've got the support to kind of promote it. And one of the just, disappointing things about the funding environment and kind of unfortunate timing for this work was that the National Science Challenges as a funding body came to an end right at the end of this project. So they ceased to exist as government funding anymore. And so we kind of got this kind of key piece of momentum, and then we're now in the next phase, but without that kind of support from the actual funding body, which has been which is a challenge. It is a challenge, but we all understand funding environment challenges.
The equity-focused funding challenges right now, and broadly speaking, across both institutions and locations. Steve has a question.
Yeah, really terrific talk and fabulous work. I've admired your work from afar, and it's just wonderful to hear it presented. What I was wondering about was, I was hoping Kelly Ashburner was on today, but she's not. But she worked in Karen's center, on cancer, health equity, and did a project to think about how to identify whose judgment around what is equitable and what is not. And so came up with this idea of this stakeholder and equity data-driven implementation SETI model, which fundamentally worked with the community to look at their data collectively, to say, oh, let's look together at where are the gaps, and found in that pilot that the one way to think about equity, all the boats rise. Another is to look at which group is most disadvantaged, and discovered in this wonderful pilot that again was sponsored by Karen's Center here, that the stakeholders, the community, didn't realize where the real gap was. By looking at their data together, came up with an equity target. So I guess my question is how do you know what is inequitable, what is equitable, from whose perspective? And is it a qualitative thing? Is it a quantitative thing? Possibly both. But to what extent does data help here? And maybe in some settings, data is not available. But I'm just wondering about this issue of perspective of the target to improve equity, from whose perspective and with what data? Does that make sense as a question?
Yeah, sure. Yeah. So we're fortunate in New Zealand that we have quite a lot of both quantitative and qualitative data about Māori health outcomes. And we can get it down to district. So we have 20 health districts in New Zealand, so we can get it down to district level. But you're absolutely right. The next step is working with community, and in our case, we had a Māori advisory group, or Kāhui it was called, as well as a community advisory group. And in our stakeholder group, there were representatives from Māori organisations and Māori staff from the mainstream system. And so we were able to engage with them around the data and what's important. I think we still don't particularly, in some areas that works well with early engagement and saying, what are the key issues for you as a Māori community? Which of these things are important for you? And in some cases, we still don't do that particularly well. Often it will be like, for example, with lung cancer screening, we know, we've seen the clinical trials, lung cancer is the leading cause of cancer deaths. There's awful inequities. And we know that lung cancer screening reduces mortality by, about 20 to 26%. So we then went to the community and said, hey, there's this thing you can do to prevent people from dying. Are you interested in doing something? And so, sometimes sometimes communities come to us and say, hey, we're really worried about, I'm talking generally, we're really worried about suicide in our community. What can we do about it? So it's kind of can work both ways.
That's really helpful. Maybe one last question, I suppose. Something that's been I've been thinking about as you've been talking is, and maybe related to what Steve was saying, which is what is equity and for whom? And one thing that feels really different and really lovely about what you've done is you were able to build off these Watani principles. And so you had a sense of sort of what your target group really felt were the key principles around, I don't know, intervention design or delivery. And we're a lot more heterogeneous typically in the way we think about equity. Is it Black? Is it Hispanic? Is it low socioeconomic status? And I don't know what the question is here. Just, do you have any thoughts or recommendations for how to think about maybe more heterogeneous populations when thinking about equity, perhaps?
Yeah, I mean, often we focus particularly on Māori because of the Treaty of Waitangi. But the Pacific population, so in New Zealand, the Pacific populations are people who can have ancestral links to particularly Samoa, Tonga, Niue, the Cook Islands, so the kind of Western Polynesia. And they experience significant inequities as well. So we do, and we'll often separate out. And of course, you go through the same processes in terms of making sure you engage with the appropriate Pacific people, all of those same processes and around engaging with Māori and thinking about Pacific equity. How do you do it? Do you have the right people on your team? All of those kinds of things as well. Yeah.
Okay, great. Well, that was really, really, really helpful. We really appreciate the time that you both gave to us, and we'll pop up the website one more time for folks. Otherwise, yeah, thank you so much, and just check out for next month Danielle's call in the chat for any works in progress that people would like to give. So thank you so much.